coming in at quite a good rate. That is brilliant. Thank you so much and welcome. I'm going to give it just another couple of minutes and then I'm going to start the webinar. If you've joined us, you've come in for the Gastrointestinal Illness in Children webinar. This is a statewide webinar. It's being organised by Northwestern Melbourne PHN, but it is for all people working in PPCCs across the state of Victoria, or maybe you're in a co-badged UCC, or maybe you're just really interested in gastrointestinal illness in children in terms of an urgent care / emergency response. We're not looking at chronic management today. Okay, I think we've got quite a few people here now. I'm going to start the formal proceedings, and I'd like to start by acknowledging the traditional custodians of the land on which our work takes place. Now, for me, working from Melbourne, that is the Wurundjeri Woiwurrung people, the Bunurong people, and the Wathaurong people. And I'd like to pay my respects to elders past, present, and emerging. I also pay my respects to any Aboriginal and Torres Strait Islander people in the meeting with us today. Now, we've got a few housekeeping things, but let me just get my slideshow happening. And hopefully you can now see my slideshow only. Can you give me a thumbs up if that's correct, Celia? Yeah, beautiful. Okay. Okay, so we've got some housekeeping. All attendees are muted. Please ask your questions via the Q&A box. It makes it a lot easier to run a webinar because I can click off if I've answered questions, and that way I don't miss anyone. This session is being recorded. You will receive a link to this recording and a copy of the slides in a post-session correspondence. Questions will be asked anonymously to protect your privacy. Please ensure that you've joined the session using the same name as your event registration or phone number if you've dialed in. Northwest Melbourne PHN uses Zoom's participant list to mark attendance, and certificates and CPD will not be issued if we cannot confirm your attendance. If you're not sure if your name matches, please send a chat message, which is different from the Q&A, but if you go for the Q&A, it doesn't matter, we'll sort you, to Northwest Melbourne PHN Education to identify yourself. Now, before we get started tonight, I am just going to give you a very quick presentation about Health Pathways. Now, Health Pathways Melbourne is an online resource developed by Eastern and Northwestern Melbourne Primary Health Networks in collaboration with local healthcare professionals. I'll be showing you how to navigate the Melbourne Health Pathways, but other PHNs throughout the state have their own version of Health Pathways with a similar setup. So my colleague Chris will post the other Health Pathways links in Basecamp in the next few days, or if you're getting the recording sent to you, it'll be in that email. To access Health Pathways Melbourne, go to the website address melbourne.healthpathways.org.au. Health Pathways Melbourne contains information specific to the Eastern and Northwestern Melbourne PHN catchments. There are a couple of ways to get into Health Pathways, but the crux of it is that you will need to register a username and password. If you don't have access yet, you can click on register, which brings up an online form. We can also organise automatic login for you so you can access Health Pathways without a username and password. Just email the team at info@healthpathwaysmelbourne.org.au, and remember, you will get a copy of these slides. The process of developing content for Health Pathways is a collaborative effort between local GPs, specialists, allied health providers and other subject matter experts. Health Pathways Melbourne provides clinicians with a single website to access a comprehensive collection of locally relevant clinical information and guidelines designed to support general practitioners and other healthcare providers in delivering consistent and evidence-based care to their patients. Health Pathways aims to enhance the clinical knowledge and promote best practice. It improves the quality of pre-referral workup and to reduce delays with referrals and provide you with information on local services available to your patients. This is the landing page, and it's pretty intuitive, which is great. Search bar is towards the top of the screen, and the pathway links are to the left side. Each pathway has an optional send feedback button in order to ensure the information is up to date and useful. The advantage of using health pathways for PPCs or co-badge clinics or anyone choosing to use it is that it's helpful local knowledge for clinical staff who may be new to the area or locums, or it contains GP-only direct hospital contact numbers, and it improves the quality of pre-referral workup and reduces delays with referrals. Here are some of the links that you might find in relation to gastrointestinal illness in children and related pathways and resources. This is all on Health Pathways. This slide illustrates a list of relevant possible referral pathways and resources for gastrointestinal illness in children in general practice. Thanks for listening to this presentation. Again, you'll get all of this in your slide pack when you get the email. I am now going to hand over to Dr. Celia Bagshaw. Dr. Bagshaw is a fellow of FACEM. I'm sure there's some cool and groovy way of saying that, Celia, but I don't know what it is. Of course, this is the Australian College for Emergency Medicine. Celia is employed full-time as a paediatric emergency physician. She is also currently the educational supervisor for all ACEM trainees in the Monash Medical Centre Emergency Department. And I'll just stop sharing. So Celia, you can take over.
Thank you very much, Stella. Can you see my screen? Okay.
Yes. Yes.
Brilliant. Thank you very much. Thank you very much for having me along this evening. Yeah, I'm one of the FACEMs at the Paediatric ED at Monash Clayton, and our ACE and DMT. I was really interested to hear about those healthcare pathways, and I feel like I should have had a look at them before I prepared this talk. But in this talk, I'm just going to cover the acute management from a kind of ED and urgent PPCC perspective on vomiting, diarrhea, constipation in children. From a caveats point of view, I guess it's important to acknowledge that I think we do see a different population of people, and certainly there's a different population in primary care versus ED, and probably a bit more of an overlap in the PPCC patients. So I'm more than happy to take questions throughout the talk. I think Della's going to keep an eye on the Q&A, and happy to be challenged on anything I've said, anything that you feel that you would manage differently, so that it's more of a discussion and a sharing of ideas and management than me just kind of talking at everybody. My approach to anything in emergency medicine, so any unscheduled care visits, when I see any patient at all, this is me on the right hand side, so at average day in the paediatric emergency department, I am seeing a large population of children, most of who have a benign self-limiting disease, a few of who have, or maybe none within a single shift, have a time critical illness, and then a group of patients in the middle. And our challenge, both in PPCC and in the emergency department, is to pick those children who have a time critical illness or an emergency illness and give them appropriate care amongst all the children that have benign self-limiting illness. And I think that's a real challenge for all of us. So whenever I see anybody ask them, sort of when I've seen the patient, taken the history, examined the patient, I think to myself, what time critical illness could this be? Is this a child with evolving sepsis? Is this a child with intussusception, for example? If I don't think it's any of those things, what condition could this be that don't need a specific treatment within a 24, 48-hour period? Things like appendicitis, for example. What else might it be that it might be useful to diagnose, but not necessarily by me? Things like, a child with abdominal pain may end up having inflammatory bowel disease, but if they're not acutely unwell, that might be a diagnosis that's reached a little bit further down the line, or celiac, that kind of thing. And then finally, if it is a benign self-limiting illness, which one is it, and how am I going to best advise the parents to care for the child? Vomiting is an incredibly non-specific symptom. So when you work in the emergency department, when you look at the screen of patients waiting to be seen, there's always one or two words describing their presenting complaint that the triage nurse has put in. And over the years, I've seen children who've had their complaint as vomiting end up having a final diagnosis of heart failure or a stroke or ovarian torsion. So it's an incredibly non-specific presenting complaint, and therefore the key to all of it, as with everything in medicine really, is the history and then the examination of the child. We'll talk a bit more about some of the points in the history, but in terms of vomiting, one of the things that I always hone in on is when people talk of it as a bilious vomit. I would say a lot of parents and also medical staff will describe bilious vomiting when they actually mean gastric contents, yellow vomit. So this picture on the right is, if you walk between Monash Children's and the EDs, there's this bit on the floor where someone's done a bit of artwork. And for some unknown reason, they've managed to make it look like 3 different types of baby vomit. So the yellow one on the bottom reminds me of the gastric contents, the white in the middle is the milky vomit, and the green one's the one that you worry about, the bile stained vomit. Obviously, so we take a really good history, an examination, and I think with children in particular, the general state of the child from the end of the bed is probably the most useful piece of information to get in the exam. And then sometimes a judicious use of some bedside clinical tests like a blood sugar level or plus or minus a ketone, and we'll talk about the relevance of them a little bit later.
Celia, Celia, I've got a question here.
Yeah, go.
Does bedside test include urine dipstick?
It does sometimes, and I've sort of covered that a little bit later on in the talk.
Cool. Okay.
But yes, it does, definitely. So in terms of things that you obviously normally ask about a child that's vomiting, do they have a fever? So pointing you more towards an infective illness, or their clearly doesn't tell you whether they've got a bacterial sepsis or a viral illness. Do they have diarrhea? And what are their bowels doing? Are they in pain? And a child who's got significant pain, not sort of just a bit of discomfort prior to a loose poo or prior to a vomit, but constant, moderate to severe pain is a real concern. I always ask, particularly in the younger population, about episodes of pale floppy episodes, which can be a key sign of intussusception, which is something we'll also talk about a little bit later on. Sometimes you may see a child who has presented with vomiting from raised intracranial pressure. So again, you're going to start asking them a little bit about headaches. It all really depends on where those initial questions in the history go when the parent or child starts telling you what's been going on. And always in the back of your mind, particularly, well, I suppose in any age range, if it isn't sort of quite making sense to you, and you're not quite sure what's going on, consider, has this child been accidentally or intentionally poisoned, either by themselves or somebody else? If they're sort of having more regurgitation, severe pain, perhaps with vomiting, could they have swallowed something catastrophic like a button battery? And then obviously in your older kids, drugs and alcohol can come into play as well. In terms of people that just clearly need to come straight to the emergency department, the big one would be anyone with bilious vomiting. So if you're actually vomiting up green stuff, you need to come to the emergency department for further assessment. Some of those children will just be having bilious vomiting from, endless gastro-induced vomiting with the bile sort of stains. But generally bilious vomiting needs a really close look. I would say really based on my experience that neonates who are vomiting, not just positing after feeds, but young neonates within a few weeks of birth who are actually vomiting do need to be seen. Those children that can't walk because they're in so much pain, that look really, really unwell, obviously need to come in. And yeah, anyone with significant pain, by which I mean simple analgesia isn't really cutting it, it's limiting their ability to move around. I think they should, based on your assessment and your judgment, of course, be the sort of children that I would expect to see coming straight to the emergency department.
Celia, can you elaborate a little bit on why is bilious vomiting so concerning?
Because it's usually a sign of obstruction. So particularly in the neonatal population, it can be a sign of malrotation of volvulus, which is a surgical time-critical emergency. Yeah, it's generally a sign of obstruction. So rather than your gastric contents coming up, there's a blockage lower down. And so beyond where your bile duct drains into your bowel, causing the vomiting, the bile to come back up.
Thank you for that. I've got another question too.
Yeah.
When you ask a parent if their child is floppy or pale, the majority will say yes. Is there a better way of framing this?
Yeah, so when I normally, it would be like a toddler, so usually about 2 months to 2 years, the interception kids. And what happens is at the time of they vomit, they go really, really pale, almost losing consciousness, and then they pick up again. So rather than them sort of going, oh, you're talking to the parent, oh, they look really, really pale to me, they seem really lethargic, and the kid's sort of sitting there looking around at you. It's episodic, and it can have completely resolved. Those would be the ones that would be more concerned about. So I generally do ask if a child's come with isolated vomiting without a febrile illness, and they've had a vomit or two at home and with no other cause, I do say at the time of vomiting, did your child sort of go floppy, almost, like they were losing consciousness? And then I find the vast majority of parents say no. It's not often they say, oh, yes, they did actually. I thought they were going to pass out. And to be honest, most parents will mention it. Like, it's pretty obvious. They'll mention the fact that the child had an altered period of consciousness. There's two conditions that can cause that. One would be interception, and the other is FPIES, which we'll talk about as well, which is they sort of present in slightly different ways.
Brilliant,
Does
thank
that
you.
answer the question?
It does. We've got a couple more. Can you just go over and summarise the neonatal concern that you mentioned earlier? Neonates who are vomiting, not just positing. Can you just summarise what the concern was with that?
Again, it's because these ones, neonates are notorious for presenting with sepsis without a fever, with metabolic illness presenting with vomiting, with malrotation, obstruction, such as duodenal atresia and so forth. And initially, some of the ones I've seen have ended up having a final diagnosis of malrotation of volvulus or obstruction, have initially presented with non-bilious vomiting. So the last one I saw came in with a big yellow vomit, and about, of course, it was 10 o'clock at night, and then had another large volume vomit in the emergency department, and that was all that kid had. That child looked well. They had normal observations, and their lactate on the first gas was slightly raised, but obviously you wouldn't have that opportunity in primary care. So because neonates are a population who are more likely to have a serious bacterial illness, more likely to have a surgical cause, more likely to be announced into the world they've got a metabolic issue, I think if they're having large vomits, they should, in my opinion, based on the children I see, which I appreciate different ones that you guys see, they can come in for an assessment, possibly bloods and so forth. What else was I going to say? And the other thing is, I guess, as well, if they're having significant vomiting and they're only a few weeks old and they're not going to keep their feeds down, they're at risk of becoming dehydrated much more quickly than an older child.
Brilliant, thank you. One more question, and it may be something you're going to answer in a few minutes anyway. Do you advocate pain relief? If yes, what should we use?
Oh, 100%. There is literally nothing I can think of where I wouldn't give pain relief straight off the bat. Like, it makes everything easier. It is far easier to tell where a bone hurts, whether a headache's serious, whether a tummy pain is significant, with pain relief on board. And we would normally start off with just paracetamol and ibuprofen, and weight-based dosing. And then, unless it's and those would be more than suitable for the kids coming from GP. So those two. So on Dantatron, I'm happy for that to be given to anyone. Paracetamol, ibuprofen. There's no reason not to give those medications unless there's obviously an allergy. Occasionally, if someone comes in severe pain, the variant torsion and so forth, they obviously get intranasal fentanyl or something stronger straight off the bat. But no, there's no reason to withhold pain relief from any of these children. So infections. So your infections, obviously, usually children with infections already have a fever. Not always, you can get people with cold, sepsis and so forth, but it's pretty unusual. There's usually a history of a fever. And to us, the fever is the parents objectively thinking the child has one or a measured temperature. Clearly, the majority of children I see with vomiting and fever have a viral gastroenteritis that's self-limiting. But we often do consider a urinary tract infection in isolated vomiting. The children that I personally tend to try and get a urine on are children with a fever, vomiting, so vomiting multiple times, and sort of under the age of about 1, because they're a slightly increased risk. If they've got diarrhea, I don't tend to bother. But if it's just vomiting and a fever with no other focus of infection on the clinical history, so they're not snotty or coughing or with a big pussy ear, then I would consider getting urine on them, and that's often a bit of a kerfuffle trying to get a clean catch. And the children that can talk and describe their symptoms, unless they've had a history of urinary tract infections, if they're not describing any symptoms suggestive of a urinary tract infection, so no abdominal pain, no frequency, no dysuria, etc., I wouldn't bother in them. And then in the sort of above the age of 1 but pre-verbal, again, it sort of depends, like history of a urinary tract infection, history of urological abnormality, good going fever for over 24 hours with vomiting and a bit of tummy pain and no other symptoms at all, then I would generally probably get a urine in them. If it's a child that's just had symptoms for a few hours and is well and has no history of these sort of things, of urinary infections or renal tract anomaly, then I usually watch and wait for them, because often, and particularly in a non-toilet trained child who's ambulant, it can be really difficult getting a urine from them. So those are the ones that I would normally test.
Thank you so much. I've got a question for you, Celia.
Yeah.
Can we use Zofran wafer for under 4 years old? If no,
yes.
What antiemetic can we use?
You can 100% use Zofran. We use ondansetron wafers, and this is all on the RCH CPG for gastroenteritis. You can use it from the age of 6 months and 8 kilos. Personally, I tend to do it if you're 1 or the other. So if you're 6 months and 7.5, I'll let you have 2 milligrams. If you're 8 kilos and sort of 5 and a bit months, I'll probably let you have 2 milligrams. So it's dosing of, if you're 8 kilos to 15 kilos, it's 2 milligrams. 15 kilos to 30 kilos, it's 4 milligrams. And 30 kilos plus is 8 milligrams. And we basically never really use any other antiemetics in ED. So, occasionally if you've got someone with something strange like cannabis hyperemesis, you might use something different, but yeah, it's absolutely fine to use it in those age groups. So infection, again, obviously, you're going to consider other causes of a fever. You've got fever and vomiting, and the things you worry about, of course, are meningitis, pneumonia. But again, you're guided by the clinical exam on those things. Gastrointestinal obstruction we've briefly touched on, so it can occur at any age. It's malrotation and volvulus, particularly, so an anatomical predisposition to a volvulus can occur at any age, but seen much more frequently in neonates, and it may not be bilious initially, but they do tend to look really unwell. But initially, some of the neonates don't, but they would become unwell. There is this condition, hypertrophic pyloric stenosis. And that's just where the muscle in the outlet of your gastric outlet muscle hypertrophies and gives you progressively worsening pyloric stenosis. And the babies, usually male, but obviously a female infant can get it too. They're usually about the age of 2 to 6 weeks, and they get recurrent, progressively more forceful, larger volume vomiting. That is always non-bilious, because the obstruction is proximal to the biliary duct going in, CBD going in with the bile. And the typical issue of these kids is they sort of usually start vomiting a little bit, and you think, oh, well, whatever. And then over the next few days or week or so, they have much bigger vomits. It's after every feed. They may start losing weight or having poor weight gain. The baby's usually well appearing and quite hungry in the initial stages. So they want to feed, but then they have a big chuck. An ultrasound scan is the gold standard for diagnosis. And the initial management is IV fluids and correction of electrolytes. So if we do see a baby around this age who's having non-bilious vomiting and no clear other cause, we would normally do an ultrasound to look for polycystic stenosis. It can be equivocal in the early stages. So I've had a few kids over the years who the initial scan's been sort of all probably okay, and then they've come back a couple of days later and it's been much more diagnostic. And those children have been fine. But yeah, that's another thing to think of in that younger age group. So intussusception. So there's a few diagnoses in my line of work that you just don't want to miss. So obviously the big ones, always bacterial sepsis, myocarditis, and then intussusception's another one. And it is one of those things you just have to have a high index of suspicion for, because we see so many children with vomiting, and an incredibly small proportion of them have intussusception. The usual presentation for these children is they have episodic abdominal pain with vomiting and period of episodic lethargy. And they can appear remarkably well in between. And the exam can be unremarkable, although they talk in the textbooks about developing a sort of mass in the right side. I've never actually found any children with that. Usually it's an anatomically normal gut. Some of them have a lead point, but you wouldn't know that when you first see them, of course. Any age can get it, but it's commonest in 2 months to 2 years. The children may start off with diarrhea as well, that could confuse the issue. And the sort of thing that you may remember from medical school about this having red currant jelly stools are a late sign, and that's by the time the child's actually getting bowel wall ischemia, when they start to have a nappy that looks a bit like that. And clearly by the time you get something a bit like that, you're kind of a bit more aware that there's something going on. So it's just worth asking the question, I guess, in these children. And, you know, I saw a kid this week who I was convinced this child had intussusception. He'd had this huge vomit out of nowhere, gone incredibly pale and floppy, to the point that the ambulance service had actually back-called him through, and the mum had called an ambulance. You know, that's how well that child looked. And his ultrasound was normal, and he was completely fine. But I think the probably thing to remember with those ones is that intussusception can happen, and then it can decompress itself. So they may get symptoms that self-resolve. So yeah, just another thing to think about when you're seeing and assessing a child, and particularly if the parents seem really quite concerned the child looks quite unwell for a period of time, but is now perked up and did appear to be quite uncomfortable at the time. And obviously those kids with the suspected or intussusception, straight to the emergency department, and we put an IV, get an ultrasound done urgently. It's probably one of the only reasons you can get an ultrasound done out of hours, because you're looking for intussusception. And abdominal X-ray is not sensitive, well, less than 50% sensitive for intussusception. I just thought I'd touch on endocrine and metabolic disease. So it's another reason that I think it's worth having a low threshold to refer young infants, so sort of young neonates, to ED with vomiting.
Celia, can I just ask a question?
Yeah.
Just going back one slide, can intussusception recur?
It can. So it can decompress itself, and then, but you can get recurrent intussusception. Probably more common if you've got a lead point. So you can get intussusception occur if you've got HSP, you know, when you get the vasculitis, and some of them can be in your bowel wall. Or I guess some other people might have little polyps and things that can do it. I would have thought in a child who has a normal bowel wall anatomy, it'd probably be unlikely to recur after. So the treatment is an air enema, sorts most of them out. Sounds horrible, but you know, it's better than having an operation. A small number need to proceed to a laparotomy. I think it's more common, isn't it, after the rotavirus vaccine? They talk about that as one of the potential side effects. Yeah, so endocrine metabolic disease can present with vomiting. Clearly the big catch-out one that is DKA. Usually those kids look unwell. But I've been aware of one child who presented to not our emergency department with symptoms consistent with DKA and vomiting, but didn't have a BSL check. They weren't a known diabetic, so it's a first presentation type 1 diabetes. So maybe worth checking a blood sugar level in a child who is vomiting without a fever, looks unwell, maybe getting some of those symptoms of acidosis, such as the raised respiratory rate. But again, these kids look sick. I thought I would touch on accelerated starvation. It's something that I hadn't heard of a few years ago, but increasingly something that we're aware of in the ED, probably without particularly good evidence to guide management. When children, young kids generally, who don't have much in the way of glycogen stores, so sort of busy toddlers, when they get sick for any reason, their body goes into starvation mode if they don't have any carbohydrate intake going in. And so I saw a lot of this up in near the Austin, because it's quite a high socioeconomic population. So the kids get sick for whatever cause, they're not eating anything, they're sipping on water for a day or so, they burn through their glycogen stores and they start producing ketones to keep their sugar level up. And the ketones then is thought make you feel worse. So you get more tired, you get tummy aches, you start vomiting a bit more, and you go round and round in this spiral. And in severe cases, the child can become hypoglycemic. So sometimes when you see children,
I've just got a couple of questions. We just need to cycle back to interception. And we just want someone just to clarify, just to make sure we're really clear, just checking that if the child is floppy and pale during a vomit, or if it's episodic, that is concerning. Otherwise, not. Is that right?
Yeah, that's right. Yeah. So it's this sort of, I mean, Chris wants to chip in as well with her experience, but the parents describe that the child becomes like they look like they're uncomfortable, or they go really, it's a behavioural thing, I think, they go really sort of pale and floppy and barely responsive. They and then they perk up again along with vomiting.
If you want to have a good on interoception a bit later as well, and we can develop that as well.
Good. Cool. Great. Okay. And one other question. Are Down syndrome patients more prone to interception?
I honestly don't know the answer to that question. I don't see why, but I don't know.
I don't think so. Not in, my reading with this.
Brilliant. Okay. Thank you.
Accelerated starvation, they get high ketones and they feel more unwell, and that's one of the rationales that I have around using, which I'll talk about in a minute, using apple juice or so a little bit of carbohydrate in for mild dehydration in kids. But sometimes if you check the blood sugar and the ketone, you'll find the ketones are like 5, and you give your ondansetron, you give your apple juice, and the kid still feels like crap and still spews, and then those ones, I guess, need to come into ED for probably for a drip for a while. When I say that about the number of 5, I kind of pluck that out of the air. No one really knows, what level of ketone should give symptoms, whether you should manage these children differently. SDS is just something that we've observed. The one other thing I wanted to talk about in terms of a cause of vomiting in children, that again is another thing I hadn't heard of a few years ago. FPIES. So FPIES stands for food protein induced enterocolitis syndrome, and it's a non-IgE mediated gut allergic reaction to some foods. And the foods that produce it are not the things that you would typically think of as causing an allergic type reaction. So things like rice and oats are often precipitants. It usually presents around the time new foods are introduced. So children often present around the age of 6 months or so when they first start having, a bowl of oats for breakfast or whatever. And the kids vomit and vomit and vomit for a good few hours often, big volume vomits. They can then get to the point of circulatory collapse, not where they arrest or anything, but they can sort of have lots of vomit and then go all pale and floppy over a sort of hour period because they vomited so much. And they can also have some diarrhea. So it presents with, within about 1 to 4 hours, multiple repetitive vomiting. Sometimes the kid goes pale and floppy towards the end of those episodes of vomiting. And they come into ED sometimes and they respond really, really well to ondansetron, usually. Occasionally have to do a bit more, like put a drip in. But usually by the time they get to us, they're actually on the out, and so they're sort of picking up again. They don't get other allergy symptoms, so they don't get hives or wheeziness or stridor or anything like that. sometimes it's usually relatively easy to identify. I know they've had rice once or twice and then they've started doing this. Though there's a nice handout for parents from ASIA that I usually give the parents, because, you know, they're really worried about these kids. They've been vomiting. They were all pale and floppy. Now they look fine. And give them the ASIA handout. They read it and they're like, oh yeah, that's exactly what happened. And those children will need to steer clear of that precipitant food, but may well grow out of it in the next few years. And I presume, but I don't know, that they get referred to an allergist. I should have checked them on our pre-referral guidelines, but I think that they usually get referred to an allergist and then have a food challenge a little bit later on.
Celia, I have a question for you. Do you give Novorapid insulin before sending the kid to ED if you suspect DKA with extremely high glucose said over 30 milliliters? Is that 30 mmol?
Millimoles, probably. Millimoles. No, I've never heard anyone suggesting. I mean, I'm talking about working in the centre of Melbourne. So, what the advice would be for someone working in Tennant Creek, Tennant Creek Hospital. Anyway, working in a regional, remote, rural community would be different. But I've never heard an endocrinologist where I work suggesting that insulin's given pre-hospital. Because we normally put in a drip, start giving the fluid, and then start giving it insulin after that. So I don't think you would know.
Cool, thank you.
It's not the high sugar that makes them sick. It's the dehydration and the acidosis. And in fact, if you look at the Royal Children's Guideline, we actually want to slowly reduce the sugars to quickly change it, because then the osmotic shifts are too great and they can get cerebral edema, because sodium and glucose are both osmotic active agents. But yeah, we tolerate the high sugar. We, in the first instance, treat the circulatory collapse. Like if they're in shock, you have to give fluids. But at PPC, I think is to diagnose and recognize it, maybe on densitron to stop the vomiting.
Brilliant, thank you.
I realised I've just pulled out a slightly older version of my talk. I was putting this at the beginning. When I give one of these talks, I'm always like, I must not screenshot stuff from the Royal Children's Hospital clinical practice guidelines. But then I end up doing it anyway, because I really like this differential diagnosis chart on their vomiting CPG, of all the different causes of vomiting. And I think I've just gone over most of them. So we've talked about infection, touched on raised intracranial pressure, but clearly that's something you sort of start to tease out in the history. Obstruction, poisoning. I can't see the next one because I've put my bar across it. Volvulus. Chris will probably touch, I would have thought, on testicular ovarian torsion, both of which are acutely painful conditions. I didn't want to talk about GORD, but I saw there's a healthcare pathway, so that's good. Pyloric stenosis is inception, FPIES, and then your older kids, endocrinometabolic, so DKA, and then teenagers may present with an eating disorder, of which vomiting can be a sign if they're purging. But again, there's usually a lot more coming out straight away in the history that would suggest that as a diagnosis. And then obviously drug use and pregnancy. Yeah, that's a good point. Should be checking a pregnancy test in anyone who's menstruating, because that can present with vomiting. So after considering all of that, I've usually decided that the child just has simple infective gastroenteritis. When do I need to worry about someone with gastro? Well, if they're less than 6 months, they want at least a doctor review, and may need an ED review if they've got significant fluid losses from vomiting plus or minus diarrhea. These are, I don't know, need to find. So I managed to stick something right across the middle of my slide, and I then cut my slides. So what's the word underneath age? What does it say?
Length of illness.
Length of illness. Sorry, yeah, that's it. So these are things you want to know when you see the child. Obviously, their age, how long they've been unwell for. A lot of the children we see have been unwell for just a few hours. So it's important to acknowledge with the parents that at the moment the child's okay, they can go home, but they may need to represent, put an X, Y, Z. what's been going in and staying down, what's been coming out, how much diarrhea they've been having, try and quantify it, as well as, if possible, how much urine's being produced, but that's very difficult with the kids in nappies. And then what is the general state of the child? Do they look well? Are they jumping up and down the bed? Are they sitting up and interested in everything? They're probably not hydrated. They're probably well hydrated if they are. I do tend to ask about travel history because we do see a few kids coming back at the end of school holidays with salmonella and so forth from overseas, or from Australia, but more commonly salmonella typhi from overseas. And kids with vomiting illnesses that have complex medical conditions, particularly complex cardiac conditions, so univentricular hearts and so forth, or obviously children with an endocrine or metabolic disease, they would have a much lower threshold to be referred to the emergency department, but most of the parents would know that. So what do we do? So we see a child who has had what we've decided is infected gastroenteritis. They've had some vomiting. They may or may not have developed diarrhea. They may or may not have a fever. The simple thing is that in our population, most children do not become significantly dehydrated with simple gastro for a day or so, or a few days. And in my experience, the ones that do have actually been either vomiting profusely for over a day, so not keeping anything down, or have frequent large volume diarrhea and have done so for a day or so. It's actually, I think, the diarrhea that's more dehydration than vomiting. As I said, some kids can develop accelerated starvation, but most children can be managed in the ED or primary care with a dose of ondansetron and some guidance around fluids management at home. When you see someone with fluid loss from vomiting, plus or minus diarrhea, you do want to make sure that you do some kind of hydration assessment. However, having said that, we as clinical practitioners are really poor at assessing hydration. We tend to usually overestimate it. This is, again, from the RCHCPG. And the thing I sort of take away from this is that really, if a child is alert and responsive, looks well, is interested in their surroundings, they are going to be at most mildly dehydrated, less than 5% dehydrated. Caution, I would say, when I say our population, when I speak to my colleagues at work, say up in Darwin or Alice Springs, they talk about how they often see Aboriginal Torres Strait Islander kids that are extremely dehydrated and still running around the department. So I'm talking about the kids that I see in Monash B. Clayton. When you're assessing hydration, if you've got a recent weight, that's absolute gold standard. It's really, really helpful. So if my colleagues have seen a baby 2 days before with vomiting and diarrhea, and then they come back 2 days later, and I can see that they've lost 5 or 10% of their body weight, I immediately know how dehydrated they are. But most of the time, we don't have the information. My sort of spiel with our registrars is if you're not significantly dehydrated, you don't need to be rehydrated. We could just check that you're able to tolerate some fluids after ondansetron, and then you can be discharged with advice. Treatment-wise, you absolutely can use ondansetron in a child over 6 months. And this is the weight-based guidance from the Royal Children's Hospital clinical practice guideline on gastroenteritis. Personally, for a child with mild dehydration, who I'm looking to get home if I'm getting to tolerate some fluid and for the family to feel confident to manage the child at home, I just offer them clear apple juice. Rather than insisting they have oral rehydration solution. Some kids like ORS, but the vast majority don't. And there is a bit of evidence around that, which I'll come on to in a minute. So I offer them clear apple juice, or ask the parents to buy some clear apple juice, and give them a cup of apple juice, cup of water to continue to sip on at home, and that will hopefully ward off ketosis. They can use ORS if they want, but it's more expensive. It's not got much sugar in it, and a lot of kids don't like the taste. I do find a lot of the time I do caution parents against pushing food intake, especially the first 12, 24 hours of the illness, because a lot of parents really want their kids to eat and just kind of take that pressure off the family and the kids. Say they're going to be fine, they can tolerate no food going in, let's just manage them with a bit of apple juice, a bit of water, a bit of time, and you can see how you go.
Yeah, I've got a question here.
Yeah.
Can we just get you to talk a little bit once more about pain relief? Panadol definitely is safe, but ibuprofen in the context of gastritis/ulcer, that's not, though both are common in children. How about buscopan, dicyclamine, especially clinically, if gastroenteritis is quite a confident diagnosis?
So, I mean, listen, I don't worry too much about ibuprofen in an otherwise healthy child. If a child's severely dehydrated, so, they're very, very lethargic and are well appearing, they may have had diarrhea for many days, they're clearly going to need admission and rehydration, then yes, I may hold off the ibuprofen until I've got their renal function back. But in terms of gastroprotection, the problems that you see in adults where they're taking it regularly, where they get gastric erosion, just doesn't seem to occur in kids. And a dose or two of ibuprofen for those children is fine. I don't have much experience with buscopan, to be honest with you. I get experience, maybe I'm jaundiced because it gives me hallucinations, but we don't tend to use it in ED. I don't know why. I don't know whether it's been proven to be ineffective, but personally, my go-to is always paracetamol, ibuprofen first, and then very occasionally you have to give endone or something, but those are kids with or fentanyl or IV morphine, but those are children that are coming in under the surgeons with appendicitis or ovarian torsion and so forth. Chris, have you got much experience of buscopan in kids?
Buscopan is hysocin, so it can cause
that's right.
arrhythmias. So yeah, so if you got a dehydrated kid already, you don't want to cause arrhythmias. And there is a thing with gastro. The reason why the child's got gastro is the body's producing all this fluid and having cramps to get rid of the pathogen, right? So if you give buscopan, you're stopping the protective mechanism as well. So you might prolong the illness. And mainly because buscopan is hysocin and it can cause bradyarrhythmias, and that's why I don't use it. Maybe in a 13-year-old, 14-year-old teenager, but not in little kids.
I've got another couple of questions.
Mm-hmm.
Do you suggest abstaining from dairy products in the first 24 to 48 hours, considering the possible temporary lactose intolerance?
So yes and no. I just include this slide as the RCH handout screenshot, so I tend to give you all the RCH handout, and it does give some information around formula feeding for infants. So I tend to say, if you're breastfeeding a baby, carry on the breastfeeding. If you're formula feeding a baby, if I've checked they can keep the formula down in ED, I send them home on it, but I generally follow this sort of advice here. In an older child, I don't see the reason that anybody needs to drink milk acutely, and I sort of probably, for no good evidence, worry about the sort of high fat going in and making them all likely to spew. So I generally say, for the first 24, 48 hours of the illness, just stick to simple fluids like water, like dilute or full strength clear apple juice and water as well. And then slowly introduce a light diet, like a bit of toast or a few bickies, but try to stay clear of high fat things. The temporary lactose intolerance is a post-infective thing. So they get the gastro illness and that sort of clears the system, but the diarrhea continues. And, after a couple of weeks, the kid's still having diarrhea. And that's thought to be due to a temporary sort of your gut loses its lactase from the villi or whatever. For those children that present with a kind of post-infective ongoing diarrhea, if they're formula fed or drink a lot of milk, then I'd normally advise that the parents buy a lactose-free formula or a lactose-free milk for a few weeks. And then I never know whether it gets better because I work at ED, but it got better for my nephew. But yeah, I think that's the advice. It's for the post-infective diarrhea, you have to worry about the temporary lactose intolerance. But more acutely, there's this sort of general advice about what you do with formula-fed infants.
I've got a comment here, which I think is confirming what Christina was saying. Buscopan's product information says only for over 6 years old.
There you go. I'll probably skip over this slide, but it's just a little bit of evidence around the use of apple juice in the mildly dehydrated population in ED. This is so if you want to give a handout to parents, the RCH Kids Health Info gastroenteritis handout is quite good. I was just going to briefly talk about diarrhea, which in our setting is usually part of an acute infective illness. And as I said before, often is the thing that actually makes the children more dehydrated. So the children that come in profoundly dehydrated tend to be the ones that had diarrhea for a few days. Blood is sometimes present at the stool, which may raise a suspicion it's a bacterial illness. But generally speaking, if the child is still well and having some blood in the stool, but it's active and drinking and well hydrated, then I just tend to send off a stool sample for those kids and leave it at that. And then if it comes back with a bacteria, will get run by the lab. Treatment is the same for diarrhea, really, in terms of hydration, in the setting of gastro, in terms of focus on hydration. If they've got more chronic non-bloody diarrhea, there's an RCH primary care liaison guideline, but obviously you've got your healthcare networks as well. Health pathway. Blood in the stool is a relatively common ED presentation, and generally speaking, if the kid is, obviously not got signs of intussusception, and as I said, it's a late sign, so it'll be pretty unwell by then. It's well hydrated, drinking okay, and we think it's probably part of an acute infective illness, then I just tend to send off a stool sample. I don't tend to do bloods acutely. It can be a presentation of cow's milk protein intolerance in some infants, but I decided that was probably outside the realms of this talk. But that's one of the reasons that we sort of see infants with a bit of blood in the stool that are otherwise healthy coming to ED. In an older child, we do get from time to time kids that come in that have got much more of a chronic picture, but it's a chronic abdominal pain, altered bowel habit, blood in the stool from time to time. And then we start thinking, well, do they have something like an inflammatory bowel disease? And those children will often get a bit more of a workup, which could be done in the community by doing some blood tests, including inflammatory markers and consideration of a fecal calprotectin if those inflammatory markers were raised. But again, you're going to get a little bit more on the story than a kid just coming in with a short history of fever and diarrhea for those children. I thought I'd just quickly mention hemolytic uremic syndrome, because again, it's something that just goes through my mind when I think of a child that's had a diarrhea type illness, and particularly if it's been a bloody diarrhea. HUS is a horrible condition where they get a hemolytic anemia with acute renal failure and thrombocytopenia post-infection, 90% of the time because they've had a Shiga toxin-produced E. coli. So not Shigella, but an E. coli that produces Shiga toxin. Most of these children present 5 to 10 days after the bloody diarrhea has come on, with symptoms that suggest that a serious illness: oliguria, hematuria, anemia, pale and unwell, renal failure with edema and hypertension. So clearly, if a child does present like this, where they're becoming more unwell after an acute infective gastro, then these ones would again require an immediate ED referral. But it's pretty rare, this condition. I've only seen it 2 or 3 in my career. Any questions on any of that?
Yes, I do have a question. Do kids get, and here we go, this is a big one, do kids get pseudomembranous colitis giving the antibiotic they've exposed to?
Is that the C. diff thing? Is that what pseudomembranous colitis is?
Mm-hmm. Do kids get pseudomembranous colitis given the antibiotic they have been exposed to?
Is that isn't that C. difficile? Pseudomembranous colitis? They can, they absolutely can, yeah.
But we don't see
Sorry,
it
go ahead.
common in children. We don't see C. diff that common. It's I don't know. I would expect it to be more of an adult thing, because kids get amoxil and cefalexin all the time, right? For minor things, for a lot of our illness. But I know in all the stool cultures that we check in PET, I don't see a lot of C. diff. Do you? That I check anyway. Unless maybe the audience have seen C. diff in their stool cultures.
For kids. I think the youngest I've seen has been about 18.
This participant saying, I have not seen one in kids. Wei Chen is saying he's not seen one in kids.
Neither have I. I've seen it in adults. It's more of an adult thing, I think.
Yeah, the only one I've seen it in was 18, so not a kid, and he'd had like a complicated appendicitis and then been on IV, broad spectrum nasties for a while. Probably see one tomorrow now. He said, "Oh, that will be." Okay, well, I'll talk briefly about constipation. It's funny, this talk's got some of my bugbears in it, and constipation is one of them, because I reckon a lot of kids are constipated and we just don't recognise it until they get really constipated. So it's a really common cause of abdominal pain in the emergency department. And they say like a third of kids will be constipated at some point in their childhood. I reckon it's probably higher than that. And about 10% at any one time. So the peak onset is when solids are introduced into the diet, when they're toilet training, because they sort of hold on and don't go, and when they start school because the toilets are yucky, they don't want to go for a poo. I also reckon around holidays as well, because they don't eat them. They don't have their kind of brain food at lunchtime or whatever they have at school. They're just eating fun foods. Entirely breastfed babies may only have one soft poo every 7 to 10 days, and that's completely fine. And it's not an uncommon presentation that you get these little babies coming in who haven't had a poo for 7 days. If they're entirely breastfed, not had solids, are not on a significant amount of formula, and they're well, then and they've had they have a soft poo rather than a hard poo. So it's got to be really nice and soft. Then that's just normal for them, and you can just reassure the mum that they're making the most of that gorgeous breast milk. Other than formula-fed babies, however, can get constipated. So it's all about how how solid your poos are. I'm always really careful when the juniors come up to me and say the child's had normal poos. When I go and ask them, this happened yesterday, go and ask what normal poos is for the child, you often find it's a type sort of 3 or 2 stool every 2 or 3 days. That's normal for them, and now they haven't had one for 5 days. So when someone said they're having normal poos, just ask them what normal means to them. Kids with severe constipation may develop soiling with chronic diarrhea because that's overflow. And again, this isn't a talk about more chronic conditions, but if they've got sort of chronic diarrhea, occasionally it's actually severe constipation with overflow. Most constipation is functional, so there's no underlying cause. It's just that they've got themselves into a cycle of holding stool because it's painful to pass, and they get more constipated and go around in that cycle. This is on the R6 website, but there's a clear diagnostic for the criteria for constipation, which actually is quite strict if you think about it, like only having 2 poos a week or less. What we see in ED a lot of, though, is kids that got colicky pain. And when you take a good history, it's been going on for a week or 2 weeks. And they've been having a poo every 2 or 3 days for the last few months, and now haven't gone for a few days. They're losing their appetite. They feel a bit sort of crappy and lethargic. And the pain sort of colicky and comes and goes, and they can still carry on about their day, but they're just not as active as normal. Occasionally they have some fissures, so they get some blood on the outside of the stool as well, and it's painful. Sometimes you need to get a history from the kids, because again, people come in because they're really worried that their child's got a serious illness like appendicitis, and they're a bit concerned if you're sort of just saying, I think they're just constipated. So often if you just ask the kid to tell them what's been going on, the sort of kid that's a little bit older and goes to the toilet by themselves, you start to see what the problem is. In terms of red flags in constipation, you shouldn't really get constipated hard stools under the age of 6 weeks. So that's a bit of a red flag, may need more of a workup. You do sometimes see that in formula-fed infants, but as a red flag. If a baby didn't pass meconium within the first 24 hours of their life, that may mean they've sort of got something like a Hirschsprung's disease. If a baby has sort of ribbon-like stools, this is talking about little babies really, and ribbon-like stools, that could be an anorectal malformation. Clearly a child that's not gaining weight appropriately or losing weight, and if they've got an abdominal mass, of course it's quite concerning, although sometimes you can feel feces in the left iliac fossa on kids, but it's got a very distinctive feel to it when it's stuck there in their rectum.
Celia,
in terms of acute
management, I've got a question. How common is Hirschsprung disease? Who should GPs refer the patient to? Paediatrician or paediatric surgeon, as biopsy may be required?
Surgeons. There'd be a surgical thing to refer. So if you're concerned a child may have it because they've got red flags or their constipation, but they don't need an acute, because the bad ones with the long segments will present like probably before they even go home from hospital. Most children in Australia don't go home from hospital after they're born until they've had a poo. But ones with sort of short segment Hirschsprungs may not present until a bit later, and may have had some of these on their red flags on their history. And they should be referred to the surgeons. And I don't know about other services, but certainly our surgical registrars at Monash are really responsive to phone calls and can give quite good advice on the phone if needs be, if it's something a little bit more acute that you sort of, do I send a kid in or do I not? Acute management of constipation from an ED perspective. I tend to just go off this sort of handout. So if you put RCH, Royal Children's Hospital constipation management, this comes out as a PDF that you could just print off and fill in. For a bit more information so that parents can really read up about constipation in children, kind of get their head around the fact that it's something that needs to be treated for a good few weeks or months. The Conquering Wheeze and Poos handout is pretty good for older children because it talks about what happens when you hold on to stool and about the sort of rectal dilatation and the need for regular toileting, that kind of thing. The general rule is that you need laxatives for longer than you've been constipated. You really sort of retrain the bowel. So for some kids that just had a holiday where they didn't drink enough or eat enough veggies, it might just be a few days on Osmolax. But for other kids, it may be they actually need to be on laxatives for many, many months. And clearly their their regular GP would need to be involved in their ongoing care. We don't tend to do an abdominal X-ray to look solely for constipation. I know that some of my paediatric colleagues do sometimes do X-rays where they really want the parent to understand that this is the problem. So they want to show the parent the fecal mass in the rectum and that kind of, sort of so that people can move forward with the diagnosis and treat it rather than becoming really concerned about the pain. But generally speaking, we don't do an X-ray in an acute setting unless we are looking for obstruction. And that would be an unusual, like if you think a child's got obstruction, then they're coming to ED anyway. So yeah, I just fill this in. And generally, I would go with Osmolax as a treatment. So Osmolax can be used. If you look at the RCH website, you can actually use it from just a few months of age if you want to, but it clearly needs to be prescribed. There's a nice clinical practice guideline handout for that. But Osmolax with the dose on the right-hand side, or Movicol, remembering that both of these need to be put in the correct volume of fluid as per the packet, which is for 1 large scoop of Osmolax, 1 cup of the fluid. But it can be any fluid, really, fluid that has a bit of taste to it, because even Osmolax you can taste, I think, in water quite clearly. If they are not able, and that's what I normally start with, either Osmolax or Movicol, but if the child has already tried them and won't take it because they won't drink the volume or they won't don't like the taste, then a Parachop would be sort of second line with the doses as written there because it's a much smaller volume. Disimpaction regimes can be useful for children that are really bunged up. It would be fair to say that we very, very rarely admit children for an inpatient disimpaction. It really is reserved for children who have failed a really good go at community management or a complex child with cystic fibrosis or something like that. We very rarely use enemas or suppositories as well. We usually try really hard to get them home on the outpatient disimpaction regime seen here, with follow-up either by their regular GP, help them titrate the doses, or with our paediatric rapid review clinic if we think a paediatrician needs to see them within a few days' time. And yeah, inpatient disimpaction is pretty uncommon to do, and it's usually done by a nasogastric in a younger child, so it needs a bit of sedation on board to get that down. And always remembering for the parents, it's not a quick fix. They're still going to need to have laxatives when they go home. And that concludes my talk, and that's a picture of Bristol, which is the home of the Bristol stool chart where I used to live, just up over that hill there. So I'm happy to take any further questions if anyone's got them. If not, we can move on to Christina and her talk on tummy aching.
That was absolutely fabulous and really understandable. And thank you so much for allowing me to ask those questions during your presentation. I am now going to ask you to stop sharing your screen and I will share mine. Hoping that you can all see the correct slide, which is about Dr. Christina Fong. If Christina, you can give me the thumbs up if that's what you're seeing. Great, thank you so much. Now, Christina trained as a fellow of the Australian College for Emergency Medicine at Monash Medical Centre and had further paediatric emergency medicine training at Boston Children's Hospital. She returned in 2000 to work in the Paediatric Emergency Department and Monash, where she still works currently. Christina is an advanced paediatric life support instructor and enjoys training medical students, residents and registrars, and anyone who wants to care for sick children, which absolutely includes us. And Christina is going to talk about abdominal pain in children.
Okay, can you see and hear me? Okay, so welcome to my little hole in the wall of a study. And I'm very excited to talk to you about tummy ache in children because it's an incredibly common symptom, but can, as Celia alluded to, can be very tricky. So thank you, Celia, for a very good talk, and I've learned so much about constipation. All right, so the objectives of this talk is to revise the pathophysiology of abdominal pain. I'm not going to spend too much time, but I think if I talk about how the nerves run, you can understand why it's such a non-specific symptom and why we have radiation and stuff like that. And abdominal pain, like a lot of things in pediatrics, the diagnosis and how we think depends on the age, because from age 0 to 18, they go through so many development stages. And how do you know a non-speaking child has got abdominal pain? And I learn from my patients, and I think stories stick in the head as opposed to just textbook tables. So I'm going to share with you some of the cases, some of the mistakes, some of the things that I've missed, so that you don't miss them. And a little brief summary and approach on how to diagnose and investigate abdominal pain in children. Okay, so I've got picture of rocking horse because I don't want to talk about rocking horse manure or rocking horse shit, but some truths about abdominal pain is it's an incredibly common symptom in pediatric emergency. And then it's acute versus chronic. Sometimes we see patients coming over 3 weeks, couple of presentation, and then it's obvious as to why they've come. Is it functional or is it something acute? Most of them by far will be normal, it'll be fine. You know, it's a symptom of something else. Some will be constipated and many of them will be functional, but at least 1 or 2 will have something serious. And that's where we all get very nervous about. We don't want to miss anything. And the problem is because we're dealing with a population of different ages with different conditions, there are many, many, many etiologies. Okay, so a very brief run through on the pathophysiology of abdominal pain. It is a very vague symptom. And I don't know about you, when I ask a child, does it come and go? Where is it? They're almost always pressed in the center, in the umbilicus. So the reason being because really visceral pain is from the stretch of smooth muscle. So when you get a dilated gut, it's painful and it's actually very vaguely innervated by splenic pathways, and it's not specific to a certain organ, it's very localized. It's not until when there's somatic pain, which is the nerves that run in the peritoneum and in the abdominal wall, that you can feel the localized pain, the deep inspiration pain, or pain when you press on the abdominal wall. And then there's the referred pain, and in particular, there are 3 very important nerves that run in and around the abdomen that can get irritated and give you pain. For the famous one, phrenic nerve, that innervates the diaphragm, can give you shoulder tip pain. Obturator nerve, twisted ovaries, you can get lower back pain and you get inner thigh pain, and then the genital femoral nerve as well. And not only that, in the child, the distance between your chest, your abdomen, and your pelvis and your testicles, they are very close by. So any irritation or inflammation can spread to, say, from the chest to the abdomen, abdomen to chest, pelvis to abdomen. So the actual anatomy makes the localization of pain very tricky. Not only that, when you, this is reiterating the same thing. Not only that, when you look at the dorsal spine, some of the pain fibers spill to the dorsal spine as well. So let's talk about some of the causes of abdominal pain through the ages. This is going to be a little bit textbooky. It's actually in the Royal Children's website. Don't forget the bubbles and a lot of textbooks. And I know you're going to get a copy of this slide. So it's a bit listy, but I think if you don't know about these things, you're not going to look for it. So I'm not going to talk about every single condition. So yes, I'm so sorry, it's a list. It will be on the handout. So neonates, as Celia's alluded to, there are a lot of inborn errors. There's malrotation, volvulus, intestinal obstruction. Hernias is probably the most commonest of the surgical conditions we see in neonates. There's Hirschsprung enterocolitis, necrotizing enterocolitis. These kids are very, very sick, and even we don't see an emergency department. They get diagnosed fairly early, and there's always interception. And I'm very sorry to say we live in a society when that's non-accidental injuries, and we do see some trauma in neonates and infants. Okay. So throughout my talk, there'll be pictures of my son. That's my son when he was an infant. So again, interception, hernias, MECOs, testicular torsion, ectopic trauma again. And then we're starting to get into constipation, gastroappendicitis. There you go. Oh, back one. Yeah, so it's exhaustive, but it's not inclusive. But these are some of the things that I've seen and have thought of. And as we come to adolescence, trauma becomes higher because boys and girls are doing much more dangerous things, riding bikes, jumping, playing footy, rugby, and soccer, they get kicked in the abdomen. And in adolescents, there's testicular torsion, not technically abdominal pathology, but they can get referred pain to the tummy and present with lower abdominal pain as well. And as young women start to have periods, they can get pregnant, they can start ovulating. So some of the gynae conditions, plus when they become sexually active, STDs, PIDs. Okay. Now, very importantly, I think this slide's probably more important than those list of things to remember, are the non-abdominal causes of abdominal pain. So what I mean is these are patients that present with tummy pain, but the actual pathology is not in the abdomen. So UTI, it's a pelvic organ. They can get cystitis, pain in the lower abdomen, and if they get pyelonephritis, it can radiate up to the renal angle. DKA, as Celia spoke about, hernactia purpura, another poorly understood immune-mediated inflammatory disease that we see in children. And lately, PIMS-TS, which is the post-COVID inflammatory syndrome, they often come with tummy pain. In fact, when COVID was around, I don't know whether Celia remember this, I used to say, oh, it's another COVID appendicitis. So what it is children coming with right iliac fossa pain, fever, vomiting, and you refer to the surgeon, says appendicitis, we watch them and it settles, and it's related to COVID. Do you remember that, Celia? I used to call it COVID appendicitis. Sickle cell crisis. So if you got a kid with the past history of sickle cell crisis, they come with tummy pain, the first thing you need to make sure that they haven't got they're not in crisis. Sepsis often present with tummy pain, especially if they got ischemic gut. And as Celia said before, sometimes they just come in vomiting because they've got ischemic gut, and then it becomes obvious they got sepsis. As they grow older, they start taking alcohol or taking overdoses, and then the psychological and functional. But right up top here, pneumonia, especially mycoplasma pneumonia, they're called atypical pneumonias for a reason, because they're atypical. They don't typically give you chest symptoms. They give you headaches, tummy pain, diarrhea as well. Pericardial pericarditis, myocarditis can often present with epigastric pain. And then I kind of then think of all the adolescent or older kid testicular ovarian torsion, ectopics, and sexually transmitted disease. Okay, so story time. So there's a 12-year-old girl with Down syndrome, presents with right lower chest pain, and these are my real patients. And she attends special school. There was no injury, and she said she was dancing when the pain started. As you can imagine, most Downs kids are wonderful. They are smiling. They're usually very positive. She was unable to give an accurate history, and all she could tell me was what she was dancing. And she was actually afebrile. Her tummy was soft. Her chest was clear. And I thought, well, maybe she was a bit tender in the right anterolateral kind of lower rib area. And I said, you probably got a musculoskeletal strain. And guess what happens? 2 days later, my director said, remember that girl that came in? I hate that, you know, when your doctor says, remember that case that came in? Well, she's got appendicitis and her dad's complaining. So do we have a question?
Christina, we've got a question. Can kids get pancreatitis?
Absolutely. There's a girl who is, I think she's 12 or 16 that keeps coming to emergency with chronic recurrent pancreatitis. Yeah, so pancreatitis is caused by many things. In Australia, we say alcohol, gallstones, but it can be due to drugs. A lot of our children, unfortunately, post-chemo, a lot of chemo causes pancreatitis. Some viral infections cause it. And like I said, there's a girl that comes to our ED with recurrent ones, and we kind of got an alert. Yeah. Yeah, and some kids do get gallstones too because they're, and again, I don't want to talk about rocking horse manure or hen's teeth, rare things. The problem with reading is the more you read, the more stuff, but you don't see it. It's just interesting. There are a lot of, not a lot. You can develop congenital anomalies of the cystic duct, and you're a bit more prone to gallstones or obstruction to cause pancreatitis. So yes, children can get it, to answer you. All right, so this leads me to talk to appendicitis. So appendicitis is incredibly common in children, in adults. It's just a thing. And I would suspect that as we as time changes, it's just like palmaris longus, you know, part of our anatomy will change. It's like wisdom teeth. Some kids are born without wisdom teeth. So the appendix actually does have a function, and embryonically it's just left, but it actually has got lymphoid tissues, and it actually helps with protection of infection. So appendicitis is very common in children, and it's up to 2% of surgical admissions. It's uncommon in preschool age children, but it can happen. And preschool age children are the hardest to diagnose because they don't talk. And even in older children, the diagnosis of appendicitis is very vague at the start. So I looked at a couple of studies and things. The misdiagnosis rate is quite high. It's 100% in preschool. So I think when they say misdiagnosed, the first presentation, they don't diagnose it, and then later. And then as they grow older, the pickup rate is only about 60% to the 12-year-olds, which is the time that we see appendicitis. So I said, why is it that we are so bad in diagnosing appendicitis? Because it's so common. And we are taught in medical school is on the history, they often start off with generalized colicky abdominal pain, then it moves to the right. And if they've lost appetite and don't want to eat and they're vomiting, got fever, they've got appendicitis. But how many of those children present that way? So one of the reasons why appendix is very hard to, got two questions. Do you want me to take those?
Brilliant. Thank you so much. Yep. I actually just got totally absorbed in what you were saying. Okay, first question. Does acute appendicitis always need surgical intervention?
Interesting. No. And I'll explain. So I have seen kids with diagnosed appendix on ultrasound, and sometimes and often we're doing ultrasound more and more, and there's a kid that's come in, and he was very well. I think the pain had got better, and it was jumping. Surgeon assumed it was afebrile, and the surgeon said, "Oh, just watch and see what happens," and actually got better. In the third world countries, not everybody has access to surgeons. So say if you're on a cruise or you were, I don't know, on holiday in the Antarctic, there's no surgeon. Although if you're going to Antarctic, make sure your gallbladder and your appendix is out and don't get pregnant. Anyway, that's something else. When you don't have access to it, and say you're working in a third world country, some of them do settle with antibiotics. Some of them just settle because, as I said, the appendix is got a lot of lymphoid tissue, and it's not necessarily bacterial. It's often viral. In Melbourne, in Australia, most of them get surgical intervention. Because I don't want to answer, I think for the purpose of this talk, for primary, for emergency, for primary care in Melbourne, in Australia, if you think a person has got appendicitis, the answer is yes, they should have surgery. But globally, reading studies elsewhere, there's a percentage that do settle.
Brilliant. Thank you so much. And the next question is, I sometimes get kids to hop for a while thinking if they can, it is less likely to be appendicitis. Not a rule out, but just another check for me. Am I mistaken?
No, I do that as well. And and if they can sit up from lying down without much discomfort. So that excludes signs of peritonism. It doesn't rule out appendix. So it might be early appendicitis, but getting them to jump, getting them to sit up and move around means that they don't have peritonism. So sorry, this is a lily white normal appendix, and that's an inflamed one.
One more question, Christine. One more question. What is the most appropriate antibiotic to treat appendicitis?
I'm actually going to tell you, if you diagnose appendicitis, you don't give antibiotics, you send them to emergency, because that's the correct answer in Melbourne. If you are working in a third world country and you wanted to give it, you need to cover anaerobes, so it'll be ceftriaxone, metronidazole. And I think, correct me if I'm wrong, Celia. So if previously when a kid came with appendicitis and they got fever, we used to give them ceftriaxone and metronidazole. Monash Children's and Simon Craig did a study to see if giving antibiotics made any difference, and I don't think they found anything. But if they are perforated and you got peritonism, it's ceftriaxone and metronidazole, and that's to cover gut anaerobes. So if you ever have a question about what antibiotics do I give, don't ask yourself what antibiotics do I give. Ask yourself what bacteria or what bugs am I concerned about, and then that's your answer. So the reason why the appendix is so hard to diagnose is, and 64 to 68% of the appendix sits retrocecally, right? And the next one will be the pelvic ones. So these ones will get a little bit of cystitis and cells in the urine. So often we've had a couple of kids come in with, oh, you've got a UTI, and then this, and then the cultures are negative, and then the second time around you present, oh, you got appendicitis, so sorry, go to theatre. So beware of how they present. It's very non-specific. And then there are subsequent ones, and the one that gives you the typical right iliac fossa tenderness, the pre-ileal one, and they only account for 20 pre-ileal, they only account for 2% of appendicitis. Oops, sorry, clumsy fingers. And my patient that I misdiagnosed, some of them can have a long one and they can sit very close in the right upper quadrant. So 4% sit in the right upper quadrant, some can sit in a hernia sac. And check this out, less than 0.1% sits in the left side of your abdomen. And this is not having dextrocardia.
Christina, we've got a question here. Can they present with left iliac fossa pain?
Yes, That's why I said,
It
so
is.
less than 0.1% can have pain in the left iliac fossa. There's a thing called a Rothschild sign, where you press on the left side, you get right-sided pain. So again, depends how long your appendix is and where it sits and how big the child is. You know, obviously, bigger person, the distance closer, and smaller person, distance are closer. Sorry, bigger person, it's a bit wider. And once and only once did I diagnose appendicitis on the left side, and the kid didn't have dextrocardia, but had only the lower part of the gut inverted. So you got situs inversus both sides of the above and below diaphragm, or situs inversus just the bottom side of the below the diaphragm. So
Christina, is there an average age for presentation? Is it around 6 years and above?
Actually, very rare in infants. Youngest I've seen is a 1-year-old. Common age is around kind of school age, 6 to 12, 6 to 13. And mainly because we think that's when they get a lot of viral illnesses. But I have seen it in a 76-year-old. So I think depends whether you're a gambler. So like I said, you know how I gave you, what was the previous slide? Appendicitis starts becoming common. You start seeing it in infants, and it's most common in the school age. Yeah. But there's one more thing I'll talk about, appendix, yeah. So you will read all sorts of scores, and these are the two that we are studying. And I think we're trying to find a score. These scores, it's just for you to know of. I don't use them. The validation, apparently it's been validated and it's good, but what it, for example, the Alvarado score, you kind of, you know, if you get migration of pain, you get 1 point. If you got loss of appetite, you get 1 point, and you kind of total them. If you got 10, you sure got appendicitis. But what it is it actually is giving people a guide as to whether, if it's less than 5, you don't do anything. 5 to 6, you start investigating, and more than 7, you call the surgeon. But I think one of the problems with these scores is it depends when the patient presents. If they present early, it's not a black and white kind of like a tick sheet, and you can't do it with medicine, because patients present different times of their illness. So for example, they might have loss of appetite earlier on. Some of them don't have nausea and vomiting, but if they present early, they might not have any of these yet. They might just come in with vague tummy pain. And then there's another one, pediatric appendicitis score. But I guess I put them up there because these are some of the symptoms that we've been taught, or the red flags that make appendicitis more common. So from your point of view, and from our point of view, when we first see them, is we kind of work out, are you likely to have appendicitis? If you're likely to have appendicitis, refer them to emergency, and then we decide whether they need 3 things: whether they need imaging, whether they need blood tests, or whether they need a surgeon. Sometimes I do nothing, because by the time the patient gets to us, they get better. And my best one is in the days where the beds were very hard. There was a patient with diagnosed as suspected appendicitis, which is what a lot of GPs will write, suspected appendicitis, in Williamstown, ED. They didn't have any beds, sent them to Sunshine. Sunshine didn't have any beds, was going to send to Royal Children's. They didn't have any beds, so started at 9 in the morning with the GP, and by the time came to Monash at 5, and the poor kid, I think he was only 6 years old, was fasting all day, no drip. And he's saying, pain's better, I'm hungry, no fever. So I actually did nothing and sent him home. So sometimes time helps, and we occasionally admit to short stay or keep them for a few hours to see what happens. Okay, so the three things I talked about was ultrasound, blood test, and surgeon. So ultrasound, it's only great if you see the appendix, because you see the appendix and it's normal, diagnosis excluded. If you don't see the appendix, and you get a bit of free fluid, then you say, oh, maybe they could have appendix, it's not. So the sensitivity, the test is as good as the person that does it, and it's as good as the size of your patient. So this is why when I looked at the sensitivity, it's 11.7 to 85%. No. And so it's not the best test. That's a normal appendix, and that's a big fat appendix. We take more than 6 mm size. Apparently,
Christina, can I just clarify something? When you showed us the picture of the two appendix, the actual photographs, the one on the left with the thin white appendix, that was healthy, wasn't it?
That's healthy. That's a lily white appendix. That's a big fat engorge increase vascularity. So, but I'm not going to see this. You're not going to see this unless you're a surgeon. We might see the ultrasound. So we only get to see the skin and the patient, right? So there's
I've got another question, Christina. Early appendicitis, does it require antibiotics or send them to ED?
Send them to ED. Yeah. So with appendicitis, we don't give them antibiotics before we go to theater. So if I get an ultrasound and show the inflamed appendix, if it's not perforated, I don't give them antibiotics. They get them in theater. If it's perforated or they've got an abscess, or say you don't have the ultrasound and they've got rebound tenderness and peritonism and they're looking sick, please give them antibiotics. Because you can have a non-perforated appendix and they can have peritonism and you're not quite sure because, we don't have an ultrasound yet. So occasionally I'll have a very septic kid and I think, oh my God, you've perforated it, and ultrasound takes time. Everything takes time. You make the referral, you ring them, can I have this urgent? And they said, oh, they'll need a full bladder. And then you get a PSA, you get somebody to take them. So it's not immediate. So when we give talks like this, everything takes time. And then we put the angel on to wait for the blood, for it to work before the blood test happens. So nothing's too super immediate. But if you really think a kid's sick and you think it's perforated or got collection, please go ahead, give antibiotics.
Christina, I have a question. Does nil by mouth include oral antibiotics?
So we allow fluids, and if it's antibiotics and it's liquid, it's fine. Even tablet, I think it's fine. It's only a small amount because often pre-op, we give patients lorazepam or with a sip of water. So if you want to give oral antibiotics and you think they're very sick and very septic and you've got oral stuff only, it's still pretty good. And besides, if you got an acute abdomen and you perforate it and you need to take somebody to theater, you're not going to say, oh, we need you fasted for 6 hours, so sit around and get more sicker and then we'll do you. All right.
Christina, I have another question. Yeah. We don't have access to IV ABX. Can oral ABX be good enough?
So if you think somebody's got appendicitis, I would just send them to ED, because if they've got a sick digestive system, even if you give them orally, they maybe might absorb a very small percent. They're not going to absorb much of the antibiotics. So I wouldn't waste time. So if you think somebody's got suspected appendicitis, and if you think they're super sick and they need antibiotics, you would call an ambulance, if they're perforated, and send them straight to ED. Hopefully in our community, most parents and most people would present before that it gets that bad. And then there are small, and there are, I could write actually 4 or 5 cases of atypical appendix. And one of them was, I had a boy who saw a GP with tummy pain, and because he was going on a cruise to Kangaroo Island, And the parents wanted to be sure because they were going on a cruise, right? They're on a ship for 4 days. So saw the GP. GP said, no fever. You got a bit of pain, but no nausea, vomiting. You don't have appendicitis. And then they went on the cruise. And for 4 days, apparently he had tummy pain. He laid in bed and didn't move. And then when he came and saw me, yeah, he was actually afebrile, but he had quite a lot of tenderness, and he'd had walled off his appendix. So he had a little collection there. So he walled it off, but came in for IV antibiotics, and when it settled, they took his appendix out. So it can be incredibly hard, because when he first presented, he presented kind of too early and didn't have all the signs. And say if the GP had sent him to emergency and we said, oh, look, tummy's a bit soft, and we did an ultrasound and we didn't see the appendix, because sometimes some doctors will say, oh, well, if the appendix is not seen and there's no free fluid, because if it's infected, it will be enlarged, you should be fine. It's a false negative, a true false negative, then there'll be falsely, there'll be, falsely reassured, and still develop appendicitis. So you're done if you do, you're done if you don't. Shall we move on? Case 2. So this boy is called TR. He was transferred from Wonthaggi. He's 6 years old. 7 days. So his illness was longer than the other child. 7 days of fever and periumbilical abdominal pain. So at Wonthaggi, peripheral hospital, they actually did an ultrasound, and they actually couldn't see the appendix. There was no free fluid, but lots and lots of lymph nodes, at least 20, and they called it mesenteric adenitis. But they obviously have heard my talk and said, if you don't see the appendix, you still got right outlet phosphopene, send them to the ED to rule out appendicitis, because it's still a clinical diagnosis. And temperature was 37.2, low grade, heart rate 102, so still consistent with appendicitis, despite seeing 20 lymph nodes. And tummy was soft, there was no guarding, and was inconsistently tender all. But in fact, the surgeon saw him and didn't think he had acute appendicitis. And they were happy that he had mesenteric adenitis. So this boy was in my short stay, and I was given instructions, oh, just discharge him, he's fine, he's got low-grade fever, and send him home. So this is mesenteric adenitis. It's a radiological diagnosis. It's not a clinical diagnosis. And mesenteric just means the nodes around the mesentery adenitis. So it's a description. It's not a diagnosis. 3 or more lymph nodes more than 5 millimeters short axis. So it's a radiological ultrasound thing. And what people don't appreciate is this. You must have a normal appendix, because mesenteric adenitis can be caused by viral illnesses, lymphadenopathy, often without a known cause, which is what all the handouts say. Oh, you've got mesenteric adenitis, it's probably due to a viral illness, you've got big lymph nodes, give you tummy pain, and it should get better in 2 to 3 weeks, take some anti-inflammatories. But you can get enlarged infected lymph nodes from virus, bacterial, inflammatory bowel disease, lymphoma. And sometimes appendicitis can give you mesenteric adenitis. So back to TR. So before I sent him home, I said they did bloods at Wonthaggi. So we checked his CRP. His CRP was 106. And I said, that's very odd. And we went to examine him, and he had a cough. So we listened to his lungs, and we could hear bronchial breath sounds. So I said, I think we better do a chest X-ray before we send him home. And this is what he had. So this is what I don't like about Zoom. I can't get you to respond. But he actually had an empyema. So that's pus in his lung. And this kid was 37.2, 37.5. Why? Because he was getting Panadol and Nurofen and stuff. But when I examined him, he was still very sore in the tummy, soft, Yeah, so beware. And he, in fact, got admitted and went up to PICU because he had it drained. He was admitted for 3 weeks. So, and I wanted to highlight this case because I was this close at sending this poor kid home to Wonthaggi, to the countryside, and miss a chest infection. So listen to the lungs. And I've had, in fact, I got the intern or my resident to listen and say, oh, look, there were, what did she say? She said, I couldn't hear breath sounds, or the breath sounds, there were no wheezes or crackles. And the reason why there was no wheezes or crackles is because it's got fluid. So you need to tap it as well. All right. Any questions on that one? So I've got a 10-month-old baby called RL and came by ambulance. And the ambulance diagnosis was presented with near syncope.
Sorry, Christina, we do now have a question. How long do they get observed in hospital once referred? I have seen children getting sent home.
Yeah. So majority of them do get sent home. So it depends on what time they come. If they come late in the afternoon or in the evening, or the surgeon's not there and they're busy, they stay overnight and they get observed. So technically short stay was designed for not more than 4 to 8 hours, but it depends when the patient arrived, and this depends how bad they are, and it depends how patient the parents are as well. Yeah, so if the kid gets better really quickly and never had a temperature, is jumping around, asking for something to eat, and you examine them and there's clearly no pain, sometimes I don't want to refer to the surgeons. I give them a call. I said, look, this patient's come in. They wanted to see you. Can you come see them? I'm quite happy to discharge them. Are you happy? Most of the time they say, yeah, send them home. Yeah, so it depends on the patient primarily, but also very importantly in our department, the time when the patient comes, because sometimes when they come from the countryside, or if by the time they travel, and the surgeon's not available, and it's not because overnight we've only got a resident, and they're not confident in ruling out, we will keep them overnight in short stay, and the longer the period of observation, the more chances we get to see how the illness develops. But also very important not to have what I call diagnostic bias, just because that hospital says it's got mesenteric adenitis, or the surgeon says it has got appendicitis, can't have anything else. And a lot of illnesses in pediatrics are dynamic, like asthma, they can be fine 1 second and they can be wheezy another second. Yeah. So, in primary care, I guess you don't have the luxury of watching over time. Yeah, so that's the main difference, I think, if you want to observe and not do investigations. Any questions?
There's no questions now, but it might be a good time for me to let you know that you've got 15 minutes left.
Oh no, I want so much to talk to you about. Okay, so this one was a syncope. So this is a non-talking baby, and suddenly went pale, was crying, and it's quiet. And the ambulance said, oh, very weird. And they did ECG and they did capillary gases, thinking it's some weird metabolic thing. How often do you see syncope in babies? Is it it's an adult diagnosis? So anyway, this baby had intussusception, like Celia said, and this is what intussusception looks like on ultrasound. So this is the inside intestine, and this is the outside, and it's folded into each other. I thought you'd like to see that because I find this is called a target sign. So it's quite diagnostic on the ultrasound when it happens. Sometimes you miss it if they're not intussuscepting. So I will rush to this because Celia's covered this. 2 months and 2 years, but really can happen at any age. It can happen in an adult who's got lymphoma. Classically, there's episodes of abdominal pain followed by lethargy and floppiness, but this kid doesn't talk, right? So you just cry or yell, but the clue is they don't have a fever, and it's the episode of lethargy and floppiness. And I think there was a lot of questions about when a child's vomiting, they're very vagal and they look as if the blood's gone up from their face and the lips are white. So after the vomiting settles, if they're lethargic and floppy, consider intussusception. And it's only the ileal colic one that requires an air enema for reduction. Okay, case 4. This is a much more acute one. So 2-year-old baby just presented with fever, vomiting, and poor feeding. And when you examine, oh my goodness me, such a tight abdomen. So I don't know where you can appreciate it. So with kids, we lie them flat, or if you can sit them up. I think this child was so sick, we had to lie them flat, and there's just gas underneath the diaphragm here. And Meckel's. So I want to talk about this because it's rare. It's only 2% of the population. It's I like this 222. 2 inches long, 2 feet from the ileocecal valve. Sorry, boys, you're more likely to have it, and it happens in the roughly 2 years old. And in the young, they tend to perforate and give you an acute abdomen. And the older kid, they can have massive PR bleeding. Just a quick embryonic journey. That's what a Meckel's diverticulum is, just left over from the vitelline duct. Okay. Oh, this is what I'm missing. I want to ask you, what do you think this is? All right, seeing I'm running out of time. These are 11 magnets stuck together. So one thing that is special to pediatrics is, for some reason, children love putting things in their mouths. And this was a very difficult case because it's a toddler looking at and came in with tummy pain and vomiting, and then had a fever, and quite guarded, very tense. And we weren't going to do an abdominal ultrasound, but we didn't think he had appendix, the urine was clear, and lo and behold, look what we found, 11 magnets with about at least 9 holes in the gut. So I had to go to theater to fix it. And the mother didn't know the kid had taken it. And then when she got home, she found all the magnets on the fridge missing. So I don't know why this kid didn't stop at 2 and kept taking them. But it's a very common condition. So I've got this child who's autistic. She's an older child. She's 7, and there's coin, there's buttons, there's brooches, there are pebbles, and there are beads. So most of the time when kids swallow foreign bodies, if it doesn't get stuck in the esophagus, so the places that get stuck is the cricopharyngeal muscle, gastroesophageal, cricopharyngeus up here, gastroesophageal junction, and the pylorus, because these are our normal sphincters to stop reflux, right? So things will get stuck in that. We've got normal muscles to stop reflux. If they pass the pylorus, they're usually quite safe to pull it out. Occasionally, they also tend to swallow precious jewels, and parents will filter the poo to look for it. And this is a child that had, this wasn't an ingestion. It was, I think the he's 4 years old, and the stepbrothers played a trick on him and stuck a antenna from the car, the toy car, up his rectum. So, and again, presented with tummy pain, and the 4-year-old was too scared to say that that's what the brothers said. We thought it was a nail actually, but it turned out to be, the story came out in the end. Okay, so ingested foreign bodies, beware of multiple magnets, beware of button batteries, big objects more than 6 centimeters or more than 2.5 centimeters wide, because then, and this is based on the sphincter size. There are things called supraabsorbent polymers. And they are the things, you know, when you go to Melbourne Museum or the Science Museum and you buy the little sponge dinosaur thing and you put in water and it expands. Yeah. So apparently there are toys and beads that do that. Lead containing objects. So these are the danger ones, because button batteries, especially in the esophagus, it's a medical emergency. They have to come out because it erodes. It starts eroding as soon as it touches mucosa. And then there's a small number of kids that have a condition called pica. This is a 12-year-old Sikh girl that I looked after. She came with tummy pain and she had hair bezoar. Actually, I the surgeon did send me photos of it. She needed an operation to remove the hair. So it's like a cat. So I don't want to talk about hen's teeth because common things happen commonly. And this is a boy that had constipation. So constipation would be the most common abdominal pain that you get. And I'll probably skip this because Celia's given you a very good talk, except, and that's my son, asleep on the toilet. So 95% are functional. Some of the red flags, when you examine, make sure there's no delay in meconium. Do a little perianal exam appearance. Look at the position of the perianus, the anus, because in some babies, they're born with malformations. They can be fissures. Do a neuro, because sometimes they can have occult spina bifida. If there's a little bit of hair or divot in the back, check the gait, do a lower limb neuro. And I know we talk about abdominal masses, but if they come in urinary retention, some girls come in not knowing they're pregnant. Wilms tumor can cause constipation as well. Okay, this is a good one. I need to show you this one. So this
Christine, before we go on to this case, can we ask you,
Sure.
oh, look, apologies. It's actually just thanking you.
All right.
It's wonderful and I appreciate the knowledge you've shared. So I'm so sorry to interrupt.
So quickly, this is 11-day-old term baby. Apparently passed meconium of birth. And I can tell you now it's not constipation. And it's got this amazing x-ray. So this baby, so this is a special x-ray we do because I suspected imperfect anus. She actually passed meconium because she's a girl and she developed a rectovaginal fistula. And for some reason at day 11, that fistula closed. So she developed a bowel obstruction. And in a neonate, she was massive. It was as if she had ascites. This is a inverted x-ray where we hang the baby upside down. We hold them by the legs or put the butt up and put a ball bearing at the anus and see she's got no anus. That's her rectum and that's the air. And that tells you she's got an imperfect anus. So it's a congenital condition where they have got no butthole, you know. And sometimes it's just a membrane and you can just pass a catheter through. It's something that the surgeon does, but it's technically a medical emergency. It happened over a few days, so the child wasn't too unwell. But these kids need operations. And this is why I say in a neonate, they never get constipated. If they do, examine the bottom, examine them and make a referral. So neonatal conditions are difficult to diagnose. What do neonates do? They breathe, they feed, they sleep, they poo, they pee. They only do 5 things. And if something goes wrong with any of these functions, send them into emergency. More than happy to see them and say they're fine and then discharge them. But yeah, so bilious vomiting, as we said before, hypoglycemia, has not passed meconium. So anything that's changed from their 5 basic functions, breathing, feeding, peeing, pooing, and sleeping, send them in, please. Because you can get funky, weird diagnoses like that. So we don't look at needles in haystacks. And it's so weird how Celia and I thought of the same thing because we wrote our talks quite separately and we're both thinking of all the unusual, interesting things. But common things happen commonly. But what we want to do is not forget the things that could compromise a child or, you know, send them home and they come back sicker than before. So think obstruction, think perforation, is it infected or inflamed? We don't necessarily have to make a definite diagnosis, send to emergency. Think surgical. So the way you approach things is how you think of things. And this is why I did apologize for giving you a list, but if I don't give you a list of things that can happen, if you don't think about them, you don't look for them. And if you can't remember the list, think of the processes. So my approach to diagnosis is, I'm no walking encyclopedia, but I remember my stories, and this is why I tell them to you. So are they obstructed? Are they perforated? Are they infected? Are they septic? You know, and then the history of the pain, I find it the most unreliable in children. And then hard signs, vomiting, fever, diarrhea, not opening the bowels. How long has it been happening for? I think if your process has been happening for 6 months and you're still alive, you must be all right. Any past history, do you have nephrotic syndrome? Nephrotic syndrome gives you risk of spontaneous bacterial peritonitis. Did they have sickle cell disease? You know, have they had diarrhea before? So exam, and we all can do this. Temperature, heart rate, blood pressure, or CAP return, and the weight. Because in a young baby, if they lost weight because they're vomiting a lot, it's significant.
Christina, I'm just going to give you a 5-minute.
Yeah, nearly finished. Yeah. So do an abdominal examination. Include your, when they come with abdominal pain, include your chest, include the scrotum, and have a look at the bottom if they've got bottom problems. And all you need to do is a urine full walk test, which is by the bedside, and BSL and ketones will exclude your DKA. But also important, if a child's been vomiting a lot, they might have the accelerated hypoglycemia. And a stool culture, you're not going to save any lives by sending a stool culture up. So it's not going to make a difference in your acute diagnosis. So often no imaging, but of all the imaging, ultrasound for interception, for appendicitis, for torsion of ovary, torsion of testicle is a clinical diagnosis. Even torsion of ovaries also a clinical diagnosis because the ultrasound can be normal. Abdominal X-ray, if you think there's foreign body or there's obstruction. We never do CT scan in kids apart from trauma. And chest X-ray is useful for perforation, pneumonia. And don't worry about the upper GI series. Even I don't do it. It's a surgeon thing. All right. So red flags are, oh, go back. Lack of meconium passage in the very young, loss of weight, failure to thrive, bilious vomiting, that history of floppiness, lethargy for intussusception, foreign body in a non-verbal child. The verbal child will probably tell you, but I don't know about you, but I'm seeing a lot of on the spectrum autistic ADHD children who do weird things. Yeah, so always think foreign body. Ovaries, pregnancy tests, testicles. And if you ever think you need to give endone or opioids for abdominal pain, they probably should be in hospital. Remember the non-GIT causes of abdominal pain. And yeah, this is what I haven't covered. And I think that's it. And these are some other stuff that if we had time. So sorry I had to rush it, but I've got so much stuff to tell you. So many stories.
Christina, that was so understandable, so relatable, so thorough. Your expertise is amazing. I'm going to ask you after this to give me a couple of comments about Kawasaki's syndrome. We've had people thanking you on the Q&A. It was absolutely amazing. Your expertise is incredible.
Oh, I've got wonderful patients. So do you want me to talk about Kawasaki's?
If you can, if you'd like to give a couple of comments about it, yeah, that'd be great.
Well, Kawasaki is a favorite exam topic. So you're going to have 5 days of fever, conjunctivitis, cervical lymphadenopathy, strawberry tongue, and a desquamating rash, those things. And what it is after a viral illness, so it's almost like a PIMS TS. After a viral illness, and it's usually can be a week to 10 days or even 2 weeks, the patient, not after viral illness, but after 5 days of a fever, the body immune system, and we tend to see a lot of this hyperimmune kind of things in children, starts attacking the body's own tissues. So the treatments can be steroids, can be plasmapheresis, and immunotherapy. But the reason why we get very excited about it is in a small percentage of it, I think it's 1 or 2%. Don't quote me on that. I'm very terrible with numbers. You can get arterial aneurysms. Yeah. So they all get an echo, and a treatment for it is aspirin. So a very strange disease. It happens. Most kids get better. There is a kid that did get it twice, so it's not something you get it once, you'll never ever get it again. It's just one of those weird, unlucky, like HSP, PIMS, TS. Yeah. What was the question? What is Kawasaki's, or?
Just some, if you could comment on that, and I think you've done that very, very well. I'm going to ask you now if you could perhaps stop sharing your screen, and I will now share my final screen. Brilliant. Thank you so much. And this is actually really important. I'm going to ask people to scan on the QR code and give us some feedback if we aren't getting it right, if we aren't meeting your education needs around paediatric presentations. We absolutely have to know. It's super important. So please do scan that and please give us some feedback. You'll receive a post-session email within a week, which will include the slides and resources discussed during the session, which includes linkages to all of the health pathways across the state of Victoria. You'll get your attendance certificate within 4 to 6 weeks, and it'll take a bit longer for the CPD hours to be uploaded. Christina, Celia, thank you so much. As I said before, we've been getting thank yous in the Q&A while you were talking. People are so impressed. It's so understandable. Even I understood some of the stuff. Daniel says, only seen Kawasaki's once in the community, but the strawberry tongue definitely made it easier, and great talk. Thank you so much.
Oh,
I can't tell you how much I appreciate it. Although I was horrified, I actually kind of really enjoyed your talk. Thank you, everyone. And I'm now going to close up the webinar. Chris, if you could just close that webinar off, that would be brilliant.